Right, well, thank you for inviting me. I'm Helen Ramsey. I'm one of the consultants at the Hallamshire, and I've been one of the mentors for the dermatology cases group since it started. I'm doing a double act this afternoon, so you've got me for the first 10 minutes talking about benign lesions. I'm going to hand over to Seb Hellier, who some of you will know. He's one of our cases peer reviewers at the moment in dermatology. And then I'll just finish off at the end with a small section about acne, but very specifically isotretinoin and the new regulations and how that may impact on you. So really what I want to do is to introduce and remind you of the benign lesions referral guidelines. And actually these have been in existence for a very, very long time in Sheffield, so at least 20 years. And they were refreshed and reviewed last year by my former colleague, Sarah Cockayne, who's now retired. And they haven't changed a whole lot. And these are available on the clinical portal to refer to. And what's really important to remember, and we're actually very lucky here in Sheffield, is that if benign lesions are causing problems and they are persistently painful or catching or causing functional problems, we can treat them, and that's not the case everywhere. It's important to remember that treating them isn't always the right thing to do, and it's that old edict, first do no harm. So you may end up with unsatisfactory scars. You may end up with keloid scarring. So the image on your right is skin tags. Somebody snipped those off, and they've left itchy, painful keloid scars in their wake. And then similarly, the bottom left, you've got hypopigmentation, so loss of skin colour following cryotherapy for benign warts, and that skin colour is likely not to return to normal. Benign warts will almost always get better on their own. So don't treat them if they don't need treating. On the other hand, if they do need treating, we can do it, and there's several routes that we can do in Sheffield. What I want to do is just to take a show of hands, really, just for me to get my eye into who I'm talking to. So, of you all here, who is able to treat benign lesions in-house? Who's got access to in-house skin surgery or a linked practice? So it's a minority, isn't it? Is anybody actually doing skin surgery themselves? 2. Have I got any of our GPSIs in the audience? 3, 4? I don't think we have. No. Anyone got cryotherapy in practice? A few of you have, but yeah. So it's vanishingly rare, I think, that these things can be done in-house. But nonetheless, if you can, or you've got a linked practice, then the guidance is that you should be doing it in-house. Other options are the GPSI service, as it's still dubbed, based at Matthew's practice in Porterbrook. You can refer into dermatology. And then there's plastic surgery. And I'm going to go through some of the scenarios and just outline what's appropriate for what scenario shortly. What's really important is that to get a referral accepted by anybody, so that's the GPSI service or secondary care, you need to complete the benign lesions checklist. And again, that's available on the clinical portal. And it looks a bit like this on your left, and this is just the checklist that you need to complete. You only need to be able to tick one of those boxes to say that the patient is eligible. One of those is the what's called the quality of life score, DLQI, and on your right is the 10-point DLQI form that can be downloaded from the internet. And this is if a lesion is significantly impacting on a patient, then you can get it treated. So you need to tick all these boxes, fill it in, send it off either through ERS to secondary care, or if it's a GPSI service, that's still an email referral, and the email address is on the internet. So these are the conditions that the benign lesions guideline covers, and we're going to go through the lesions on the left shortly. On the right, it also touches on some benign skin conditions. I'm not going to talk about those in any detail today, but at the end we will touch on acne. So let's think about some of the benign lesions. Seborrheic warts, so very typical greasy, stuck-on, yellowy brown lesions, get itchy, people don't like them, they want them removing. So most of them, you can reassure them. If they do need treatment, then your options are cryotherapy if you've got it. They can be removed by curettage or shave biopsy. You can refer through to the GPSI service if you can't do it in-house, so you've got that option. They haven't got cryotherapy there, but they will shave and they will curette. You can only refer through to dermatology if there's diagnostic doubt. We see a lot of these on the 2-week wait pathway. And plastic surgery aren't interested. Benign moles. So we're not talking about the atypical moles, we're not talking about the changing moles, we're talking about the absolutely typical but troublesome moles which might be catching or itching. Again, reassure them, safety net them. You can remove them by shave excision in primary care. If you can't do it, then you can refer them through to the GPSI service. Refer to us only if there's diagnostic doubt. Certain body sites, it is reasonable to refer directly to plastic surgery. So if you've got them in awkward sites like fingers, palms, soles, and if they're very large, so the large congenital hairy nevi in children, they've got a small risk of converting into malignancy, and they can be referred through to plastic surgery. Molluscum, I don't really see these. I only deal with adults. They rarely get into the children's hospital either. Really, they should be managed in primary care with reassurance. We try to not treat them with things like cryotherapy or physical treatments because that will scar, it will hurt the child, it will stop the child ever wanting to come back again. I don't know if any of you are familiar with Moludab, which can simply be purchased, and that may hasten resolution. If you have got patients that have got very troublesome facial lesions, by all means refer them through, and similarly immunosuppressed patients can get really big, really troublesome mollusca, then we will see those. Viral warts, again, there are certain situations it's worth sending them to us. So if you've got immunocompromised patients, so transplant patients, we'll see them. Facial warts, where the topical treatments are far too irritant to use them, we can see them and we can treat those gently with cryotherapy or curette those. If you've got warts that are stopping people from working, if you've got children that are being bullied at school because of warts, then again, a referral will be accepted by dermatology. You cannot refer these to plastic surgery. We will very occasionally refer through to our plastic surgeons for help with particularly problematic lesions. But otherwise, it's management in primary care, and the PCDS website has got excellent guidelines and resources that you can refer to on managing viral warts. Calluses and corns, we don't want to see them, we can't do very much about them. Self-care, podiatry if people are really struggling, not eligible for referral. Dermatofibromas, again, we see a lot of these coming through the 2-week wait pathway for reassurance. So by all means, if you've got diagnostic doubt, refer them to us. But they're usually very obvious. They're very firm. They're positive pinch tests. So you just squeeze them between your fingers, and they're just tethered in the epidermis. And they've got a really typical appearance on dermoscopy for those of you that are using that. Again, reassurance. If they are symptomatic, they can be excised. GPSI will treat them if you can't. And to us only if there's diagnostic doubt. Skin tags. Really, we shouldn't be treating multiple skin tags. So I know our GPSIs won't. I've seen referrals being bounced back from there. Single skin tags can be. So if you've got a single cat tag that's catching, if it's causing pain, then it's very reasonable to snip that or to shave that. Again, you can do that in practice, or refer that to the GPSI service. There are 2 situations that you do need to be cautious. So if you've got congenital skin tags, you've got a baby, and they've got skin tags on the hands, it may be an accessory digit, or in the preauricular area, it may be an accessory auricle, so they should be referred through to plastic surgery. Epidermoid cysts, pilar cysts in the scalp, commonly called sebaceous cysts. these can be problematic. So we don't excise and we don't treat them when they are actively inflamed. So you manage those with antibiotics and so on. When they're in the quiet phase, if they are problematic and recurrently getting infected, then excision or enucleation is appropriate. Now, the GPSI service will do these, and they will do these almost to any size. They will do facial lesions, they will do scalp lesions. So there was some doubt a few years ago about that, but we've had that confirmed. So troublesome cysts can go through to the GPSI service. If they can't do them for any reason, they will divert them back into us. So I would encourage you to use that service there. Send them to us if there is diagnostic doubt. So if there's atypical features, we're very happy to see them and check. Very, very occasionally we get malignant transformation in a cyst. If they are too big for us, we will refer them to the plastic surgeon. So there are some body sites that we struggle with, the back of the neck, the forehead. These lesions can sit quite deeply, and we will ask for help. Lipomas, if they are big, so greater than 5 centimetres, the guidance is that they should have an ultrasound scan done, and that's something that we ask that you do, please, in primary care. The main reason being to exclude a sarcoma or other unusual tumour. And if the ultrasound scan is indicative, then they may need to be referred directly to the sarcoma team. Reassure most patients with lipomas, but sometimes they can be painful, so angiolipomas particularly can be uncomfortable. Big ones can become a real nuisance. We very, very rarely operate on lipomas in dermatology, so anything sizable would go to plastic surgery, anything smaller, the GPSI service will do. Big blackheads. Again, these come through the 2-week wait pathway. If you have a dermatoscope, it's really, really good to look at them. We do see them. We see them on the backs in elderly people. We see them on sun-damaged faces. They're usually fairly obvious what's going on. Reassure, they can be squeezed. They are not eligible for referral, unless you're not sure what you're looking at. Spider nevi, so kids get spider nevi, usually solitary spider nevi. They will get better on their own, so no one should be intervening in a child with a solitary spider nevus. Adults with large numbers, you need to think if they've got something else going on. So have they got liver disease? Pregnant ladies get them. Again, in pregnancy, usually they come and then they go away. So we wouldn't want to be doing anything. They are not eligible for referral. If somebody is greatly troubled by their appearance, you could, for example, refer to cosmetic camouflage. And I think Seb's going to talk a little bit about referrals to cosmetic camouflage shortly. If people really want treatment, they can go outside the NHS, and the vascular lasers are probably the treatment of choice. But if there's something driving them, they come back. So, nearly there. We're now on to milia. So we don't usually get these coming through the 2-week wait. These little, very tiny little white blind papules that people really don't like, often around the eyes. Usually no reason that they've come, although they are more numerous if you've got an inflammatory skin problem going on. Patients can just get a little clean pin, just express the little contents. They are not eligible for referral. Nearly there now. So xanthelasma, about 50% of these will be associated with hyperlipidemia, so please do check the lipids. They are not eligible for referral to anywhere. It used to be that ophthalmology would take them. I believe that they do not anymore. The main reason being is that treatment is fairly temporary, so we can get an improvement, but they tend to come back. So unfortunately, it's reassurance, camouflage, makeup, etc. So to summarise, you can refer benign skin lesions if they are persistently causing significant functional problems or pain. Reassure or treat in-house wherever possible. Remember to do no harm, so if it doesn't need treating, please don't treat it. All benign lesion referrals need to be accompanied by the checklist, or they will get sent back to you to be redone. Final thing about the GPSIs that I should say, if people are on anticoagulants, or if they're on warfarin, or if they're on the rivaroxaban and so on, they would prefer not to have them. they will divert them back to us. Needle phobia is the other thing that they will not have. They will take children who are Gillick competent, so if the child can consent, then they will see, otherwise it would be a referral in. That's all I'm going to say about benign lesions. If there are any pressing questions, I'll take them now, otherwise we could perhaps do questions at the end collectively. Okay, Seb, do you want to come and do your bit?
Can you all hear me?
Oh,
excellent.
That's very slick.
Thank you. Hello everyone, for those of you who haven't met, my name's Seb. I'm one of the cases GPs for Dermatology. I work alongside Helen Story and Richard Ben, who some of you may know. I've been doing the role for about 18 months and picked up quite a lot in that time, hoping to be able to pass on some of that to you today. We've got 20 minutes, so it's going to be really rapid fire and hopefully some useful practical tips and therapeutic things that you might not be aware of. Hopefully some of it lands. So that's the wrong way. Moving forward, right, this is what we're going to try and cover, so if you guys can see that up on your way. There's a lot, so we'll crack on. Urticaria, TCIs, skin of colour, pruritus, scabies, camouflage, the imaging les, which has just gone live, and syphilis. Some exciting stuff. Okay, so urticaria first of all. We're talking specifically about chronic idiopathic urticaria. Okay, in this scenario, so characterised by the very typical rash. It's a clinical diagnosis, very, very common. Adult incidence about 1 in 6 over a lifetime. This is mostly managed in primary care, partially because of its temporality. So about 50% of idiopathic urticaria will resolve within 6 months. So if we can manage it more effectively in primary care, then everyone's happy. Okay, so mainstay of treatment, as I'm sure you'll know, is the non-sedating antihistamine class. There's a few options for these. Fexofenadine tends to be my antihistamine of choice. Loratadine and cetirizine are other good options. If you do use fexofenadine, just remember that the dose is 180, not 120, and that can be increased, as I'll discuss. Other reasons to pick this one over the others, so loratadine is cleared by the liver, fexofenadine, cetirizine cleared by the kidneys. So if you've got comorbid patients, just worth considering that. Generally very safe medications. Treatment escalation, so we get a few referrals through with patients who are still flaring, who aren't on adequate doses of antihistamines, and the take-home point from this section is really to be confident in up-titrating antihistamines in primary care. And that can be done to 4 times the daily recommended dose. Okay, so for fexofenadine, so that can be 180 milligrams QDS. Now, wouldn't go in straight away at that dose, obviously. It's much better to increase it stepwise, so start with once a day, after a week go up to twice a day. Keep doing that until you get to 4 times a day. With the higher doses, patients can experience some sedation. So they're marketed as non-sedating, but they do cross the blood-brain barrier and they can cause some sedation. So for patients who drive or operate machinery, that's worth considering. Compliance tends to drop off a cliff once you get beyond TDS dosing. So something that's done in secondary care, which can be helpful to consider trying, is splitting the dose back into BD. So once you get to the top, then split to BD. So for fexofenadine, that would look like 360 in the morning and 360 in the evening. Safe and very commonly used. We wouldn't want patients being on that for a long time. Okay, so the aim is to achieve control, stop the flares, and then bring back down in a similar stepwise fashion. If you get up to 4 times the daily dose with whatever agent you've chosen, and don't mix because there's no evidence that kind of combining non-sedating antihistamines has any benefit effect. If you get up to that dose, that's probably the time at which I'd recommend referring on for consideration of secondary care review. In the meantime, you can add a sedating antihistamine as well. That's really only if patients have nocturnal symptoms that are bothering them, they're struggling to sleep, or they're having frequent flares at night. They can affect your REM sleep. They will have a significant anticholinergic burden, so just be careful with those, short-term only generally. Above and beyond that, montelukast is a good option. I know some GPs are using it in the city for urticaria, just a show of hands, out of interest, how many patients? Yeah, excellent, so a few. So yeah, it's a reasonable option, and it's used in secondary care, so please consider that. It's 10 milligrams at night whilst waiting. When to refer, well, we've covered that really. If the urticaria isn't kind of behaving as we'd expect. So urticaria is a dynamic rash, it's a dynamic process. You expect the flares and the wheals to drop away after 4 to 6 hours. If they're lasting longer than that, if they're tender, they're painful, they're dusky, or they're bruised, then it could be something like vasculitis. So please just be aware of that and have a lower threshold for referring if the wheals and flares aren't acting quite as dynamically as you might expect. Any questions on urticaria?
quick one. The fexofenadine dose that you just mentioned, 720 milligrams, is that unlicensed now?
It's unlicensed, yeah. So the BNF will say once a day at 180. So
no, what I'm saying is that usually as a GP, as you know, if something's off license, our secondary care colleagues can prescribe it, or I'm not
so
sure.
not the case as far as I'm aware with antihistamines, and with a few of the medications I'm going to discuss. So the PCDS have very good guidelines for urticaria and generally quite kind of balanced advice. So I'd recommend looking there. Of course, if there's any medication you don't feel competent prescribing, then don't prescribe it. Ask for advice. Send us a case, and we'll reply with some advice. But good question. Topical calcineurin inhibitors. So, show of hands, who's using these regularly? Who's confident in prescribing them? So fewer, not that many. Okay, so hopefully after this you'll feel more confident in what they are, when to use them, and why they're kind of really effective. So these are classified as green on the formulary, okay, for clinicians who are competent in prescribing in dermatology, which I'm sure you will agree, primary care, we are very much that. What are they? So they're steroid-sparing topical agents, okay? These have been around for about 20 years. There was some concern when they came in that they might cause increased risk of lymphoma, but that's been shown not to be the case. And there was some concern that they cause skin cancer. Again, there's no evidence for that, so they're very safe. What are the options? Well, there's three we can choose from. The first one is Elidel, that's kind of the weakest or the most moderate, going up into the strongest, which is Protopic, 0.1%. Okay, difficult to compare them directly to steroids, but that's kind of a visual guide there. So when and why do we use them? So they're licensed for atopic eczema. Elidel is licensed down to the age of 2, so you can't use them in the paediatric population, but probably an indication to refer before starting these in kids. I use them most in areas where we want to avoid kind of long-term steroid use, so where topical steroids have not just their normal side effects topically, but also additional kind of site-specific side effects. So on the face, they can cause hirsutism, and around the eyes, particularly long-term steroid use can cause glaucoma. Patients might drive our choice to use these. There's been a growing trend on social media with influencers with skin conditions driving kind of an anti-steroid ideology, if you like, and I've had a few patients come in saying they don't want to use steroids anymore as a result of this. If you have patients who come in like that, they can have quite crystallized ideas about steroids, and it can be really difficult to talk them back from that. I would, or I tend to refer them to the National Eczema Society. They have a really good helpline. They can talk to nurse clinicians about their treatment regimens and steroids, and the Eczema Society released a joint statement with the BAD recently, specifically on topical steroid use. So worth considering if you've got difficult patients. But to be honest, it's reasonable if they don't want to be on a steroid. The topical calcineurin inhibitor is not an unreasonable request. How do we use them? So they work best on quiet, kind of controlled, quiescent skin. So it can be, it might sound counterintuitive based on what I've just said, but a steroid lead is usually required. So if we're talking about the area around the eyes, periorbital dermatitis, I'd probably use hydrocortisone 0.1% ointment for a week. Okay, ointments rather than creams, because creams have more sensitizers, more allergens, and can make kind of already angry skin more reactive. And steroids should only ever be prescribed once a day. There's no evidence that prescribing topical steroids more than once a day has any effect. The only time you can prescribe them or should prescribe them more than once a day is in combination products like Dactacort and Trivalent. So a question at the back.
Sorry, I just want to clarify the hydrocortisone. Do you mean 1%?
Sorry, yeah, 1%. Yeah, that's going to be kind of not going to do a great deal, is it? Yeah, 1% hydrocortisone ointment for a week. Thank you.
Also, just to come back on that, there are supply issues with the ointments, quite widespread. Hydrocortisone not, so we might not be able to get hold of those easily anyway.
Fine. So for people who didn't hear that, there's a supply issue with various steroid ointments. So yeah, creams are fine, but generally if you can, if you've got the choice, then I'd go for an ointment. So steroid leads, to do that for a week, and then you switch directly to the TCI, whichever one you've chosen. Going back to what Tom said in your talk about letting patients know about side effects. So with these medications, they will get some initiation phenomena. It's very, very common. Tends to be mild and tends to be transient. Tends to be redness, irritation, burning, itchiness, and it tends to only last a few days. So warn patients about that, because if you don't let them know, they're going to be off steroids and now they're going to be not wanting to take TCIs. If they get particularly bad initiation side effects, then you can advise them, rather than stopping the cream and trying something else, just to apply it for 2 or 3 hours before washing it off the first few times they do it, and slowly increasing the duration until they can put it on before they go to bed and then wash it off in the morning. That's reasonable to continue in this area for 2, 3, 4 weeks, once at night, and then dropping down, like you would with steroids, to a maintenance regimen of once or twice a week. Okay, alongside obviously skincare advice and emollients, which we very much love. Side effects, so generally very few, can cause some flushing, especially with alcohol, so make patients aware of that. UV sensitivity, but as I said, no risk of skin cancer, no increased risk of skin cancer, and shouldn't be used on areas of skin that are infected. Okay, so how are we doing for time? So moving on quickly, so skin of colour. So I brought this up really just to highlight the potential pitfalls of treating patients, dermatological conditions in patients with skin of colour. So, hello. Can you hear me now? I'm going to stand over here. Hold on. Hello? Yeah. Right, so you could be forgiven for thinking there wasn't a great deal of skin disease going on, especially in the case on the right, but actually, because erythema is far less visible in the darker skin types, you just don't get a sense of the severity quite as easily and quite as quickly. So in this case on the left, that hand it's got really quite moderate or severe eczema. There's lichenification there, there's skin breakdown on the 5th MCPJ, there's significant dyspigmentation, and this patient has lichenification and dyspigmentation on not just the elbow, this elbow as well, but also on the neck. So patients might present a bit later as a result of that. We might undertreat them inadvertently as a result of that. We may even get the diagnosis wrong. So in darker skin types, we know that eczema can present more as an extensor pattern. It can be more plaque-like, so it can be mistaken for psoriasis. As well as all of this, in the darker skin types, as well as having more melanocytic activity, there's also more fibroblastic activity, which promotes and kind of drives scarring and dyspigmentation. So you've got a bit of a perfect storm of patients who their skin disease doesn't look quite as severe, but actually their propensity to scar is more significant. So have a lower threshold for considering up titration of treatment and consideration of referral, particularly for scarring conditions. It's really useful to look at imaging libraries every now and again to get an understanding of what different rashes look like in different skin types. One local kind of recent example would be, if you don't know what measles looks like in the darker skin types, then I'd recommend you go and have a look at that. Skin Deep is the one I would recommend. You can use the link in your own time. Okay, pruritus. So massive topic, huge number of differentials for itchy people. There's a lot of them around at the moment, especially the old ones who come in and you talk to them about 3 or 4 problems and they tell you just as they're leaving that they're itchy all over. This is specifically with itch without a rash. Okay, now if you have itch for long enough, you will get a rash because they'll start to excoriate and they'll get lichenifications. But this is for, all these tips are for patients without a rash. So yeah, very common, 50% of the elderly. Elderly skin is dry skin is itchy skin. So we can do a lot with just some decent emollient compliance and emollient regimens. Consider the biopsychosocial factors. Some under-recognised causes of itch, anxiety and depression, so it's really common. And itch will obviously propagate and kind of impact significantly patients' mental health, so it can be a bit of a vicious cycle. So please consider that. In terms of your assessment, the PCDS has a very good assessment pathway, which I'd recommend you look at if you have a bit of a heart sink when patients come in and they say I'm itchy. If you do an FBC and they've got an eosinophilia, it's not one of those ones to file thinking, oh, I wonder what that is, not sure. Think about drug causes. There's loads of drugs we prescribe that cause itchiness. There's a few of them listed there, I won't read them out. Treatment adjuncts, so things that I found helpful for patients and I've had good feedback from patients for. Trying to get the patients or encourage patients to cut and file their nails. They get less excoriative damage, they get less of an itch, scratch, kind of persistent cycle, and they just get more comfortable as a result. It's very simple. Top left, there's Dermatology, which is 1% menthol in aqueous. Hands up, who's using this? Yeah, a few more, excellent. So this is cheap, readily available, and patients love it because it applies. They apply it and it provides an immediate kind of cooling and burning sensation. So they can use that instead of itching. So I tell them to leave it next to their lounge chair, leave it next to their bed. not to be used instead of an emollient regimen, but on top of, okay? The other cream there is Balneum Plus, which is 5% urea. So urea is present in all of our skin, helps the skin retain moisture. In dry skin conditions, if we can replace some of the urea, there's good evidence that that increases skin hydration and health, and helps with itch. Finally, what about my back? Elderly patients often socially isolated, and they can really struggle to get creams on their back. So they can retrofit a back scratcher, which I've seen some patients do, or if they've got a hard back chair similar to these ones, they put a plastic bag over the chair, rub the cream on the chair, and then just do a bit of that. It's not perfect, but it's better than nothing, and it does give them something to do. Right, scabies, very quickly. Right, time-wise, we're lagging behind a bit. So, availability of permethrin has been in question recently. I'm not aware of any current issues, but if you're using the alternative, which is malathion, please be aware that that needs to be left on for 24 hours, not 12. Pseudo-resistance versus resistance. So there are cases of permethrin-resistant scabies, and it's becoming more of an issue, and probably will become more of an issue in time. So I'm going to talk about that a bit. Often, though, if patients come back after treatment and they're still itchy, or they've got signs of persistent infestation, it's probably pseudo-resistance, meaning they probably haven't had adequate treatment, they probably haven't adhered to the treatment, or their compliance has been poor. So, here we go. So I'm still itchy. So 2 questions to ask if you treat a patient and they come back still itchy. The first question is there persistent evidence of infestation? So looking at their web spaces, looking for nodules, excoriations, looking with a dermatoscope if you've got one, because you can actually see the mites sometimes, it can be really helpful. If there's no evidence of infestation, then you can reasonably say this is post-scabies itch, okay? It lasts 4 to 6 weeks, and that's because the female scabies mite burrows into and under the skin and leaves all sorts of detritus down there, which causes a persistent itch. However, if there is evidence of infestation, you need to then ask, have they been compliant with treatment? So it is a faff doing permethrin and getting all your household contacts treated. I tend to send patients a leaflet explaining the process, because I don't think there's any way anybody can reasonably be expected to take all that information in after a consultation and treatment plan. So if you've got a patient who's quite sharp and you think, yeah, they've adhered to the treatment, the permethrin's failed, there's other options. So there's a slightly larger parasite on this screen who's equally difficult to get rid of, it seems. He was peddling ivermectin during the COVID pandemic, which had no evidence behind it whatsoever. But it does work for scabies. It started to be used, it's unlicensed, but it's an option, okay? It's an oral dose, 200 micrograms per kilo, as a stat dose repeated 7 to 10 days later. Must treat the household contacts. This probably will present a bit of a logistical issue, because with permethrin, the contacts just go and collect it from the chemist. I don't know what the guidance is going to be with ivermectin, and it might cause problems. I'm sorry, I can't shed any more light on that at the moment. Important to treat household contacts as you would with other kind of scabies cases. There's been a lot in university students recently looking at our referrals, and it's really important, particularly in that population, to think about not just household contacts, but sexual contacts. So if they don't live with a regular sexual contact, they'll be passing scabies back and forth, and you can be asymptomatic with scabies for 4 to 6 weeks. So treat sexual contacts as well as household contacts. Bedding and clothing extermination procedures are still necessary. So pigmentation disorders, don't have a great deal of time, I'm afraid, so I'm going to skip through this, but I wanted to highlight the support for patients that is available. So Changing Faces is a really useful website to direct patients to. Cosmetic camouflage is available in Sheffield, and it's a fantastic service. There's a couple of examples of their work on the left there, so a strawberry nevus and a keloid scar, which can be made almost invisible. They will also take acne scarring, dyspigmentation, melasma, vitiligo. The referrals process is a simple email referral to Helen Fletcher. I spoke to her ahead of this talk, and she wants referrals. There's a low waiting list, it's underused. Please start to use that. The imaging les, which has only just started, so I'm not going to spend a great deal of time on this, just to make you aware that there's money available if you can attach 3 photos to your 2-week wait referrals. in terms of the images we're seeing here, so this is the difference between a dermatoscope which has been applied with too much pressure and the right amount of pressure. You can see how much more visible the blood vessels are lower down. So with a dermatoscope, please try not to press too hard. And you can also see these fluid lines here. This is because an interface has been used. So alcohol gel is perfect. Just put it on the dermatoscope and then put that on the skin. You get a much better image. You get much less light kind of bouncing back into the eye or the camera. Right, how are we all doing? We're nearly there. Syphilis. So syphilis, or secondary syphilis particularly, causes a transient eruption which can look very similar to the things we see regularly in primary care. So there's pityriasis rosea on the left, and guttate psoriasis on the right, and there's secondary syphilis in the middle. Now syphilis cases are increasing significantly, have been doing for 5, 10, 15 years, and this isn't particular to any one sexual group, this is across all sexual groups. If we miss secondary syphilis, or we misdiagnose it, say, oh, that's guttate psoriasis, that's pityriasis, it'll be better in 6 to 8 weeks. It will, because that's what secondary syphilis does. It then disappears, gets its head down, and it might only present several years later with kind of difficult multi-system pathology as tertiary syphilis. So please be aware of that in the differential for an eruption. Have a low threshold for doing treponemal antibodies if the sexual history suggests they might be at risk. These are the other pathognomonic signs of secondary syphilis. So moth-eaten alopecia, which is on the left there, so quite an unusual pattern of alopecia. So if you see that, think about syphilis, and a rash that extends to the palms and soles. Okay, so syphilis is on the up, so be careful professionally and personally. Well, there's lots of condoms around today, so I think we're all right. Okay, resources. This is my final slide. If you know the diagnosis and you want some advice about when to refer and what to do next, the BAD have very good referral guidance. I would recommend that. If you're not sure of the diagnosis, the PCDS have an excellent diagnostic tool where you can tap in morphology of the rash or symptoms, and it'll give you some options as to what it's likely to be. And finally, the Sheffield Formulary has some really useful guidelines. There's recently been an acne update, which Dr. Ramsey is going to talk about, and there's a useful actinic keratosis pathway. And that's it. Any questions? Yes. Good question. So I guess that the distinction would fall with angioedema, and I think if they're getting kind of angioedema alongside their urticaria, that might be more of a role for immunology, or if there's a clear trigger. But with chronic idiopathic urticaria, neither of those tend to apply. What would you think, Ellen?
Yeah, I think the chronic idiopathic urticarias would generally come to us. Some of those would get angioedema, but it's that very acute history that the triggers food allergy.
Did you hear that?
Probably not. You might need to.
So yes, effectively, largely chronic idiopathic urticaria to dermatology, angioedema or food allergy triggers consider immunology, but we could advise on that. No? Okay, I'll hand back over to Helen. Thank you.
Right. That was very good, Seb. Thank you. I enjoyed that. It was really good. So, I'm going to keep it short because I know that we want to get finished on time. Is anybody not aware that the MHRA produced new regulations late last year around isotretinoin and that has got implications for all of us? Has anybody not heard about it? Okay, that's a start. What I just want to do is to set it in context and let you know what our interpretation in Sheffield is at the moment. It's not just our interpretation in secondary care. We've had conversations with some of the pharmacists from the ICB and communications directly from the ICB as well about your take on things. This has really arisen due to not new evidence around the safety of isotretinoin, but due to pressure from patients and patient groups about possible long-term side effects of isotretinoin that may persist after treatment's been discontinued, concerns around mental health, concerns around suicide, and fairly recently reported concerns around sexual dysfunction, both in men and women, which it may persist even after treatment. The evidence base for this is still very, very low, but the response to it from the MHRA is the exact opposite. They have brought into play mandatory regulations now, which are summarised here, including the need for there to be 2 independent prescribers agree that anybody under the age of 18 gets isotretinoin. There are new counselling requirements around mental health and sexual dysfunction with a cooling off period for the patients. We need to do extensive assessments of mental health and sexual function before treating and during treatment. There are new roles and responsibilities that have been defined for all healthcare providers, including referrers for possible isotretinoin. And there's a whole batch of new risk minimisation materials, which includes a 5-page consent form that we need to complete in primary care, in secondary care, and lots of others. Some of we have spent hours trying to put things in place to make this function, both at STH and SCH. We are needing to give our acne patients 2 appointments before we can start isotretinoin now, and we've had to start an MDT for under 18. So from our point of view, it's been a huge amount of work. What does it mean for you? Well, take this slide in, but don't pay too much attention to it at the moment. So this is what the PCDS, the Primary Care Dermatology Society, have laid out as to what they would like GPs to do. And there's quite a lot in there, including counselling patients about isotretinoin, giving information sheets, potentially acting as that second healthcare provider. We don't want you to do all that. So, in Sheffield, we do not want you to be the second approved healthcare provider for the under 18s. And we believe that you don't want to be that either from feedback from the ICB. And that's reasonable. You're not used to using isotretinoin. And that's a big ask to ask you to do that. We don't want you to give out isotretinoin leaflets, and we don't want you to counsel patients about the risks and benefits. You probably aren't familiar with using this drug personally, and it also sets an expectation for the patients when they arrive with us that they are going to get isotretinoin as the next step. So please, we don't want you to do that. We don't necessarily want you to do any blood tests. By all means, do them. But it may be quite some months before they get to us, and we may end up doing them again. And we don't currently want you to complete a referral pro forma. But again, I'm going to ask for a show of hands at the end about how that might feel. What we do need you to do is to give us enough information in your referral to be able to move on with isotretinoin if it's indicated in a timely manner, without giving patients even more of our precious appointments. What you need to be doing is managing patients in line with NICE guidance, and that has been translated and summarised in a Sheffield acne treatment guideline, which you can access on the clinical portal. I'm not going to talk about that today. We could spend an entire hour going through that. That's not the purpose of today, but please use that. You then need to evidence that, so you need to tell us what you've been doing when you make that referral. And you need to give us enough information about mental health, sexual, childbearing potential and contraception. So the clinical information that we need to know about the reason for referral. We need details of all previous treatments, topical and systemic. We need the usual past medical history, drug allergies, etc., etc. In terms of mental health, I've had a particular plea from colleagues at the Children's Hospital to please include this in your referrals. We see many young people at the moment with self-harm scars, and there is no mention made of their mental health in that referral, and it has to be unpicked during their 15-minute appointment with us. So please, give us enough information about past and current diagnoses, even if they've not been formally diagnosed. Importantly, has any professional been involved with them? Who's overseeing their care? Is their mental health stable? If you do identify mental health problems at the point of referral, it may all be tied up with how they're feeling about their skin. It may be other things, but please put things in place to support that at the same time as referring to us, and tell us what you've done. Contraception. Have you discussed and commenced contraception if it's relevant? We've had a little bit of a win with the recent guidelines on contraception. In some ways, it's become a little bit easier for our patients. You may remember that you would be having conversations with 12 and 13-year-old girls who were nowhere near being sexually active about should they go on the pill. That is no longer necessary, thankfully. If a patient is at risk of pregnancy, then if you can get them onto the pill plus or the injection plus a barrier, that will suffice. If they have an IUD, if they have an IUS or an implant, then they are no longer going to be subject to their monthly pregnancy test with us. We can do it every 3 months. So life is a little bit easier for that group. If you are not starting contraception, please tell us why. And again, this is a little bit of a win. So obviously you've got those patients who cannot become pregnant because they don't have a uterus or they don't have ovaries, and that's fine. If you've got an individual who's only having sex with a person who cannot make them pregnant, that is also fine. That would include a man who's had an effective vasectomy and had 2 negative sperm counts, transgender men, or same-sex relationships. And this is easier because we've been having really awkward conversations with people up until now. And if you've got people that are practicing long-term sexual abstinence, and that again can include the youngsters who are not yet sexually active. So again, it's just made our life and their life a little bit easier. So please tell us that in the referral. So in summary, follow the Sheffield guidelines when you're treating. Refer to us with adequate information, including the treatments that have been tried, mental health and childbearing potential. Please consider and act on any contraceptive requirements. And a final plea, when you are referring, please take the next step up the treatment ladder at the same time. So if, for example, they've already had 2 antibiotics and topical treatments, please start the 3rd antibiotic. Put them on the pill. But please do something, don't just leave them hanging. We see a lot of referrals when nothing else has been done and they've been sent through. So my final question to the room is, it's been suggested, and there is a resource available for us to develop an acne referral form. And I've had a look at the clinical portal. There's a lot of referral forms across lots of departments for lots of things. Would it make your life easier if we had a referral form or not? Hands up for a yes. And I'm not going to hold you all to this. A hands up for a yes. And a hands up for a no. We'd rather just write a letter. It's about a 50-50. All right. Well, we'll carry on doing what we're doing for the moment, and we'll keep an eye on it. But, yeah, for the moment, we'll say no referral form. All right. Any questions about that?
Just a quick one, Helen. What happens to the cohort of young people or people who are kind of midway through their treatment with isotropes?
So there is not a regulatory requirement for us to reconsent them and go through things from the beginning. What we're doing in practice is that we are starting to bring in our the follow-up proformas, the side effect proformas. We're doing the mental health screens. We've got all our nurses starting to work to do this, so we're supported by nurse practitioners. So in effect, we've sort of got a hybrid going with those that are established, and over the next 6 months, it will be that everybody's gone through the new thing. So yeah. It's a huge waiting list. It's awful.
They might not need contraception at the point that we refer them.
Yeah.
Before they see you in clinic. But I guess it's that setting that expectation that they will get isotretinoin then, because we talk to them about it and say, often I say to people before your dermatology appointment, come back and see me about contraception. You know, if they're not sexually active at the time.
Yeah.
And then they come back just before. But again, I don't want to say
I think that's very sensible. You can say, you know, I'm referring you through to dermatology. They might use drugs that require you to be on adequate contraception. If your circumstances change, please come back and see me before your appointment. We'll obviously be, you know, checking and screening when we first meet them. We can always send them back to you. But again, that just creates a delay because they've got to be put on something. You've got to wait another menstrual cycle. And the cooling off period anyway. And yeah, and in practice, we may give them, you know, the 3rd or the 4th treatment and see them 3 months later. Some will want to move on fairly swiftly, and we will magic up slots and see them. Sorry, we're talking too much, aren't we?
Sorry. Thank you very much, Helen.
You're welcome.
Nadine and Prof. Ray.